Okay, I want to thank Dr. Paul Silberstein for giving his time today to come and talk to you about DBS and what's new with DBS, and also those who are interested in having DBS in the future. Paul works at Royal North Shore Hospital, and he's got a private practice in that vicinity as well. And he is been doing DBS for over 20 years, I believe. And anyway, I'll let him talk to you about his big career, because he's very well known neurologist, and indeed some of you may already be patients of Paul. So I'll leave it to you, Paul. Thank you.
Thank you very much, Christine. So I'm going to share my screen now. If you could just give me the heads up.
Yep. Go for it.
That you can see my slides.
Make this screen up.
Yep, and you can hear me okay?
You'll need to watch this part here, because that's the main.
Great. Okay, so thank you once again for inviting me to speak. As Christine says, we've been doing these talks for many years, and they have changed and evolved over time as the field has changed. There is definitely some familiar faces today, so a shout out to people whom I know, and of course hello to everybody else. I guess with this talk I'm going to try a little bit to cover both sides of it, so some information for people who may not have had DBS, who are thinking about it, and also some general information maybe for people who've had it who want to talk a bit more about it, and I'd be happy to answer questions. As Christine says, I've been working in this field now for more than 20 years and working in Australia now for 17. And I still find it quite extraordinary that I'm really practicing in the same area after such a long period of time. And I think that, I guess, speaks to two things. One, just how robust the therapy is and how it's really a mainstream therapy in Parkinson's disease now. But I guess also it's a kind of a flag to say we need to do more, because we need to be advancing into other therapeutic areas as well. And I'll touch on that a little bit during the talk. So I'm going to talk initially a bit about Parkinson's disease, then talk about advanced therapies in general, and then focus a bit more on deep brain stimulation and some recent advances in the field that are definitely starting to change our therapy. Okay, so you can still hear me. Can I have a thumbs up from somebody? Just so it's always interesting, these presentations, to know whether you're actually talking to people or talking to yourself, but it's very, very nice to see some faces on the side of the screen. Okay, so I am going to try and advance my slides now. Okay, so I don't really need to tell this audience too much about Parkinson's disease. It's a progressive neurologic condition. It's diagnosed based on the physical symptoms of the condition, so slowness of movement, tremor, stiffness, and at some stage walking difficulty. But we understand now that Parkinson's affects a lot more than just physical function, and we know that there are a variety of non-motor features that characterize the condition also. And we know that Parkinson's can affect people's mood and behavior, their sleep, their bladder and bowel function, and very late in the condition can cause changes in cognitive function also. So we think of Parkinson's as more than just a physical condition, even though the physical symptoms are still what we base the diagnosis upon. So Parkinson's has been very well studied, and now we also have the benefit of a number of very long-term studies following with people with Parkinson's disease for more than 25 years. And some of you may have even been involved in the Sydney Multi-Centre study, which is, pardon me, which has now got data out to 25 years. And what these studies have taught us is that Parkinson's disease tends to follow a series of clinical milestones or clinical problems that occur over time. And it's given us some feel about when those problems can occur. But we do understand that even though the milestones or the touch points and problems tend to be similar between patients, there can be a lot of variability between how quickly those problems develop and how quickly people move from one stage to another. And so I think it's fair to say in general that we take a pretty optimistic view about Parkinson's disease, that even with current therapies now, we know that patients should be well controlled with a combination of exercise and tablet therapy for 5 to 10 years plus, and that we know that a second tier of therapies called advanced therapies, which we'll talk about today, will often give people another 5 to 10 years plus of good control of their symptoms. So of course we want to see that those periods extending, and ideally we'd like to see Parkinson's disease stopped in its tracks. But we certainly know that for most people living with PD, they should be able to live well and live well for a long time, usually decades with the condition. Okay, so what happens after a diagnosis? So generally the diagnosis is made based on physical symptoms. And these days we tend to recommend that medical therapy is started relatively early, because we know that medical therapy or tablet therapy is very effective, and it's particularly effective early in the condition. And so we generally use a suite of therapies, either the precursor of dopamine, which is not produced in sufficient quantities in the brain, called levodopa, and there's a variety of different brands of levodopa that we have available, or a dopamine agonist, so a medication that stimulates the dopamine receptors in the brain. And we know that for most people, it takes 3 to 6 months to achieve consistent control of their symptoms. And we know that once consistent control is achieved, usually people have consistent control for a period of some years. The difficulty that occurs over time is that the medication dose can become a little bit more inconsistent. So people can notice that there's some wearing off of the medication, particularly towards the end of the dose or just before the next dose is due. And these lead to these so-called fluctuations, where patients experience periods where they have good control of their symptoms when they're on, and periods when their control is less satisfactory when the medications are worn off. And usually at this time we start to add in other medications, so we start to layer our therapy, and often this is very effective at re-achieving this consistent control early in the after presentation. And we know the patient can go through these cycles several times, so a number of adjustments can be made to consistently re-achieve this good, reliable control. Unfortunately, these problems of the fluctuation do tend to increase over time. And eventually, for some patients, they get to a situation where that control has become more inconsistent and more unreliable. And when patients are in this phase, it's very difficult with tablet therapy to go back to achieving that much more consistent control that we saw early in the condition. Now, 20 years ago, this was a big problem because there weren't really any effective therapies for these problems, these inconsistent and unreliable fluctuations. Since then, however, there have been a suite of therapies which have been developed which allow much more consistent and reliable control. And these are therapies we call device-assisted therapies. They're all more invasive than tablet therapies, but they can be very effective in re-achieving that consistent control when it's no longer possible to do that with tablets. And so these 3 therapies are apomorphine, an injectable medication usually delivered by a pump, duodopa, which is the most recently developed of these therapies, where levodopa is infused directly by a feeding tube in the stomach and then into the intestine to deliver the medication directly into the intestine. It gets around some of the absorption problems that we see with tablets. And then the third therapy, which of course the main topic of this talk, is deep brain stimulation, a therapy where brain electrodes are implanted, one in each side of the brain, and these are connected under the skin to a pacemaker, which delivers a continuous output and therefore delivers continuous therapy. Now, all 3 of these therapies have been shown to reduce off time, to reduce dyskinesia or involuntary movements, which are a complication of tablet therapy, and to improve quality of life. And so these are not therapies that we start lightly. We start them when we've given tablet therapy a good go, but where it's clear that tablets are not really cutting the mustard anymore. Okay, so I'll tell you a little bit about our experience. I trained in the UK at the National Hospital for Neurology in London. And we had just started, or in fact, I was the first fellow to a new unit there that was starting this treatment in London. In fact, DBS has been around since 1994, where it was first trialled by a French surgeon. It was first trialled by a French neurosurgeon. but it's actually been performed in Australia since 1997, but really got going more around 2001. And I came back from England in 2004 and started working with Raymond Cook, the neurosurgeon, and we've been working together since that time. And you can see we've done a lot of operative work now over the years. So we've treated more than 530 people with Parkinson's disease, and we use DBS for a variety of other indications. There's a few different targets that we can use, and we can use the target really to try and make the therapy address each individual person's specific symptoms. For most patients, this target is the subthalamic nucleus, but there are some other areas of the brain that we use in different conditions. These days, we tend to put in rechargeable batteries, so they're like the modern phones, but they're charged to a charging device through the skin. But previously, the batteries, we had access mainly to non-rechargeable batteries, and consequently, we've done a lot of battery replacements over the years to replace batteries near the end of life. Okay, so what does DBS actually do? So this is actually some data from our own patients. We know that most patients who are considering surgery will be experiencing these fluctuations, so variations in their physical condition through the day, and that there'll be a significant difference between when the tablets are working and when the tablets are not working. We also know that some of our patients will have significant excessive and involuntary movements or dyskinesias. And both these motor fluctuations and dyskinesias can be substantially improved by deep brain stimulation. So what can we say about what happens after the surgery? So the first thing to say about it is that when the tablets are working, generally speaking, the surgery is not better in the on-medication state post-op than before. In other words, the surgery doesn't make patient's best time any better. The big difference with the surgery is that it improves the off-medication state, so improves the severity of off symptoms. And generally what we say to people, which is a very robust measure, is that we see that DBS improves physical symptoms to the point that patients are about 3/4 of their best most of the time. So it really is very helpful in ironing out these motor fluctuations. The second thing DBS does is it allows us to reduce the medication. So in many ways, the stimulation becomes the main therapy and largely replaces the role of medical therapy, certainly in the treatment of the physical symptoms. And that reduction in medication is associated with a substantial reduction in dyskinesia, usually by about 75%. So the surgery is not more effective than the tablets, but it's much more consistent and reliable in ironing out the control of the physical symptoms. And very importantly now, in a variety of studies, DBS has been shown to very clearly improve quality of life. Okay, so the world is not created equally, and of course DBS is not as effective for some symptoms as others. And we know that DBS is the most effective for tremor and dyskinesias and rigidity, but can be less effective for walking and balance, even though that tends to improve still by about 50%. And speech can sometimes be worse after DBS, and we're going to talk about that in some more detail. Interestingly, we now understand also that DBS not only improves physical symptoms or motor symptoms, but improves a variety of non-motor symptoms. So there's good data now that DBS improves sleep, it reduces pain, it reduces urinary irritability and frequency, and it can have a stabilizing effect on mood and anxiety. On the other hand, DBS doesn't tend to improve low blood pressure, and it doesn't improve people in whom they've got cognitive change related to their Parkinson's disease. And in fact, cognition again can be worse after surgery, and that's something that's very important that we screen for over time or prior to the surgery. So that's all the good stuff about surgery. So what about the bad stuff? I think the main issue or the main risk with the surgery is the risk of the operation itself. And when we talk about major risk, we talk about bleeding in the brain, stroke, epilepsy, or death. And touch wood, we've had no deaths, but we have seen one patient who's had a cerebral hemorrhage. And we generally quote patients a figure of 1% of a disaster associated with the surgery. And many people find that very useful as a number to push up against, because if 1% sounds like an acceptable risk, you're probably ready for the surgery. Whereas if 1% sounds like an excessive risk, might not be time for you to be considering it just yet. We know, of course, that DBS is an implanted device, and so like artificial hips and knees can have problems with hardware problems or infection. And in our experience, and we've monitored infection very carefully, we've seen that about 3% of our patients have infection over the long term. Touch wood, we've been able to deal effectively with all of those problems, but sometimes that can involve partial or complete explantation or removal of the system and then reimplantation after the infection has resolved. And we know, of course, that stimulation itself, like medications, can have side effects. So let's talk a bit more about those. So I'll tell you, this is just our data, pardon me, from our total DBS experience on our complications. And you can see that the real complication risk of surgery is actually relatively low. Excuse me. One other issue that we haven't touched upon so far is the issue of getting the leads in the right place. And so, of course, like with real estate, location is everything. And you can see that early in our experience, in the first 100 cases, we did have to revise some of our electrodes, but the amount that we've needed to revise has reduced with time. And this is really a learning effect and an experience effect of having done a lot of this surgery. Okay. So interestingly, after surgery, the biggest problems or the most common problems that we see are not in the physical domain, where the surgery is pretty effective at relatively quickly ironing out the physical control of the symptoms, but it's actually in the psychiatric domain. And we know this in many ways can relate to reducing the medications too quickly. And we know that when we do this, sometimes even though people look good, they feel flat, irritable, lousy. So we have to be careful after the surgery with that medication stimulation changeover. And generally what we say to people is it takes about 6 months to get to stable control. And that's really to allow us to get that balance between the stimulation and medication right. We know that stimulation can actually cause people to have the opposite reaction. So it can cause people to be a bit manic. Fortunately, that's usually fairly easily dealt with just by changing the stimulation parameters. Notably, there is a suicide risk after surgery, which is about 0.5%. And it always begs the question, why would people suicide if they were better? And I think that what we understand is that Parkinson's has a very dramatic effect on people's lives, and there's a lot more to just managing Parkinson's well than just managing physical symptoms. This seems to be less of a problem over time, but part of the reason for that is that most units around the world now involve psychiatrists as a member, an important part of their team, and we certainly insist that all of our patients have a psychiatric assessment before the surgery to minimize the risk of major psychiatric problems after the surgery. Okay, so I had a specific request to talk about speech. Speech is a little bit the Achilles heel of surgery because speech often is not quite as good after the surgery as it was before. Now, here again, it's quite variable. So in people whose speech gets better with medication, sometimes we even see briefly after surgery a bit of an improvement in speech. But in people who have significant speech impairment before the surgery, the speech can definitely be worse. I must say that many of my patients report to me that they feel their speech has changed. It's clearly a very subtle change because I often can't really hear it. But equally, we're all very sensitive to the sound of our own voice. Like when you listen to yourself on a recording, you think, that doesn't sound like me. But we definitely do have clear data that speech does slowly get worse over the years after DBS. And so there's a variety of factors that probably contribute to that. One of them is medication reduction. So speech seems to respond more to medication than stimulation. And sometimes when we have a patient with speech trouble, we do then go back and reduce the stimulation a little bit and increase the medication to try and strike a better balance to achieve better speech without compromising the physical symptoms. We know that stimulation itself can cause some speech impairment, and sometimes changing the stimulation parameters can be very important in trying to improve people's speech. But we know that speech tends to get worse as part of Parkinson's disease, and that's also one of the problems that's, of course, a very difficult one at the moment to address. We definitely know that interventions can help, so adjusting medication and stimulation, as we've discussed, and there's also very good data that speech therapy helps. The only problem with it is like all exercise, as soon as you stop doing it, you stop gaining the benefits. But it does clearly help in those people who are willing to persist with it. So what happens in the very long term after DBS? We know that at 9 years, people's off medication state is still better than before they're off before the surgery. But we do know that slowly over time, people do lose some ground. And this is the on medication data showing that at 9 years, people's on is not quite as good as it was before the surgery. And we think that that really relates to the emergence of new Parkinson's symptoms that are not as well controlled by the surgery. So we know that many of the effects of the surgery, like effects on tremor and stiffness and upper body control, really remain lifelong. But we do see that speech tends to get slowly worse and that walking tends to get worse. So people always ask me, so when is the right time? Can I save the benefit? So one of the very clear things about surgery is you can't defer the benefit. So you can only get from surgery what you can get today, because in 2 years or 3 years' time, with progression of your Parkinson's, you won't get a significant benefit. So there does seem to be no benefit in delaying to try and save benefit for later. The only real benefit of delaying is delaying the risk. And so that's where the careful weigh up of where you're at with your Parkinson's and what the potential benefits and what the potential risks are is really the key issue. So making a decision about surgery is not really making a decision about the long term. It's making a decision about how you're doing now and how your quality of life is now and whether that's an acceptable thing or not. And that's something that we talk about a lot when people come to see us, and we try and drill down and get a bit more of an individualized approach to their symptoms. Okay, so that's a general overview of DBS, the place of it, the potential benefits, the potential risks, and the long term. So now I'm going to talk to you about some important changes that are happening in the DBS space in terms of improving the therapy. And of course, we live in a technological world. There used to be only one manufacturer of DBS devices. There are now 3 that are available in Australia. And so what we're seeing is that competition is also spurring development in this space. And that's a good thing, of course, for everybody. So there are 3 main areas in which there's been improvements recently. The first of all is refining the targeting. So tools that are helping us to really get our electrodes in the best possible location. The second is there's new devices that are allowing us to modulate the way we deliver the stimulation, and I'll talk a bit more about that. And the devices are now actually allowing us to shape or steer the current in the brain to really try and get that maximum benefit and to really try and minimize on the side effects of the stimulation. So this is Dr. Cook, the surgeon I work with, and this is us working on the operative planning station in theatre. And you can see that it's really sort of a two-heads approach to this. So we're working out the target where we want to put the electrode, and we're also working out the best trajectory in the brain. And we have very sophisticated software and improving software that's really allowing us to do that. And we can see, when I think back to what we used to see, it was like fuzzy images compared to the very high resolution images that we use to guide our implantation now. The second area is that we're seeing that we're actually now able to do scans post-operatively, which are able to tell us exactly the position in space of the electrodes. And this allows me as a program in the long term to really use that data, to go back and look at that data and go back and look at the patient and use that data to shape and try and deliver the stimulation in the best possible way. We're also seeing change in the device. So for those of you that are electronically minded, stimulation traditionally was always this typical square wave pulse. So the stimulation would just be a continuous pulse delivering electricity into the brain. And what we're seeing now is these devices allowing us to modulate not only how much stimulation or the amplitude, but they're allowing us to modulate other parameters like the pulse weight or the duration of each pulse into the brain and the frequency of those pulses. So that's giving us another tool to try and really shape our stimulation to get maximum benefit and to minimize side effects. We're also seeing the beginnings of what we call closed loop stimulation. So closed loop stimulation is like a thermostat with the air conditioner, where the device records from the brain and it alters its output in relation to what it's recording. And very excitingly, we're now seeing the first of these devices now commercially available, which actually allow us to record from the brain and then the stimulation can then respond to those recordings to actually deliver stimulation in the brain. Now, that functionality actually isn't licensed in Australia, but it is licensed in Japan and Korea. And this is going to be a really interesting thing to see if this actually changes the benefits of stimulation over time. So that's something that's just really now being explored. We've also seen the development of a whole heap of electrodes. So these are the traditional electrodes here, the Medtronic 3387 and 3389, which were these round or spherical shaped electrodes. But we're now seeing all of these new different types of electrode shapes being offered that allow us to really shape the way we deliver stimulation into the brain. So it's really like allowing us to focus the way we're delivering stimulation. So these older electrodes or traditional electrodes, which are still in use and still extremely effective, allowed a variety of shapes, generally like a soccer ball or a dumbbell or a rugby ball, for us to deliver our stimulation into the brain. You can see, though, that this might have problems. So here's a picture of what that looks like, so the stimulation field. But if we're trying to deliver the stimulation into this area, and the electrode's just on the side of that structure, you can see that as we turn up the stimulation, we might run into side effects from spreading outside the area we want to deliver it. So these newer electrodes, by contrast, which allow us to shape the stimulation, really allow us to maximize on the way we're delivering stimulation into the brain. And stimulation is very much like medication. As you turn it up, you get gradually more benefit, but then you hit a point where you get gradually more side effects. And shaping the stimulation gives us a bigger ability to get benefit with less side effects. And we're using that now in clinical practice. This is the electrode that we're currently using. And you can see this electrode, which has 4 levels like before, has these segmented leads that allow us to shape the stimulation in a direction that we like. And we can do that based on the imaging, and we can also do that based on the clinical response. And that's what we do in the programming sessions, is we gradually try things out, looking for benefit and looking for side effects, trying to get that optimal trade-off. Okay, so we're seeing a very exciting time now in DBS, where really the therapy has taken a leap to these new ways of delivering stimulation, of helping us to get our electrode in the best possible place and to really optimally direct our stimulation to get the best for our patients. So I'm just keeping an eye on the time, and I'm going to be wrapping up now. I guess I thought I should just finish talking, because people always ask, so what's the right time? When should you think about having DBS? When is the time that it's going to help you, where that risk-benefit ratio is a reasonable one? I think the first thing to say is that if your symptom control is consistent, if you're enjoying a good quality of life, surgery is not the thing to try. You should just persist with your tablet therapy, should persist with your exercise, persist with working on your mental health. These are the things that make a big difference in those early years, those first 5 to 10 years, sometimes longer, of Parkinson's disease. But when the symptoms are becoming more inconsistent, when they're becoming more unreliable, when Parkinson's is really affecting your quality of life, and reasonable tablet options have been trialed, that's really the time to be thinking about going on to the next tier of therapy. So people are often very afraid to come and talk to us about surgery, because I think they're going to go straight from the consulting room into the operation. I just want to reassure you that that's not the case at all. For most people, it takes quite a long time even to come for that first consultation. And even after that, there are many people who take months or even longer than that to really make a firm decision about surgery. I think it's a big decision. I think it's a difficult step to take. And I think it's one that needs to be very carefully considered. And that's both on the patient perspective, in terms of really feeling that it's the right thing for them and the timing is right, but also for us on the medical side. And there's quite an extensive workup process that we go through before we tell people whether we're confident that surgery is a good option for them, and what the specific potential benefits for them are and what the specific risks of it are. So I think exploring surgery is really just that. And it's, there are many people who are referred to see me, and really all we end up doing is adjusting the medication, and they may come back months or years later to talk about surgery again. But I think I'm always very mindful that we should try and change that perception about surgery, as rather than being a punishment, as being something that you have in your back pocket to activate at a time when the medications may not be doing well enough in terms of controlling symptoms. So it just leaves me really to make some acknowledgements. We've been working with a very robust and, in fact, identical surgical team now for 17 years. And that work is assisted by radiographers who are involved with the surgery and involved in the operation, and our two anaesthetists who've been working with us ever since we started. In fact, have been working with Dr. Cook now for nearly 30 years. I want to acknowledge the company representatives. So these are the device manufacturers. So they have representatives that support the operation, support the patients in the long term and the devices, and they're a very important component of this therapy overall. Finally, I just want to also acknowledge all of the people who look after and do the long-term Parkinson's care and programming for our patients. I've seen Nina and Vince, who are involved with many of our patients, and we've really worked on developing a network of people that we work with who can support people both locally and in a broader statewide sense, so that we're able to provide a service that really covers the state. And of course, telemedicine to some degree has come into that, although we've still found during this whole COVID pandemic that, of course, face-to-face generally allows us to do more than we can do online. But that said, online can be a great addition to our therapy. So I'll leave it at that. Thank you very much for listening. I'd be very happy to take questions.